Okay, good morning and welcome to our academic community. Today, June 19, 2022, we're glad to have non-native language activity. For this lecture, I want to introduce you Professor Jairo Rivera of Internal Medicine Department, University of Antioquia, and Dr. Carlos Giraldo, first year resident of the program. Doctors, thank you very much for being with us and the audience is yours.
Okay, doctor, it's a pleasure to be here. So we're going to talk first about a clinical case. And I want to tell you this clinical case like a history. So we were going to start with a 54 years old male present to the emergency department of a teaching hospital of Medellin City at 9. His chief complaint was shortness of breath. He was seen and assessed by the emergency physician, who took a history that was significant for chronic obstructive lung disease, COPD. He ordered a chest X-ray, which showed nothing acute, and he referred the patient to internal medicine with a diagnosis of exacerbation of COPD. The patient was given salbutamol nebulizer, which appears to help. The emergency physician called the intern of internal medicine at 3 a.m. to do the admission and write the admitting orders. He knew the intern. I told him he had a routine admission on a patient with exacerbation of COPD. The intern went to the ER to assess the patient. He completed the physical exam and noted a continued wheezing, a shortness of breath. He also noted a cardiac murmur and mentioned this to the ER physician, who reassured him that the murmur was old and was documented in the patient's chart. The intern wrote admission orders and started the patient on steroids and supplement oxygen and took him to the medical floor where he breathed to the nurses. He returned to his on-call room and tried to get back to sleep. At 3:30 a.m., just 30 minutes later, the intern was called by the nurse on the medical floor. The nurse said, "Doctor, doctor, the patient was continue with problems. The patient now had significant problems to breathe. So the intern went to reassess the patient, and he decided to put the patient again with nebulizer, but he noted again the cardiac murmur. The intern came back to the wrong call, and he tried to sleep again. At 4:30 a.m., the intern was again called by the floor nurse to tell the patient had deteriorated and further, and the intern should attend it immediately. The intern reviewed his chart again. He noted that the patient had no history of cigarette smoking and he was basically healthy. Given the chest X-ray did not show anything acute and there had not been a significant improvement with the nebulizer, he began to question the admitting diagnosis of chronic obstructive lung disease. He realized that the diagnosis didn't fit. Recognizing the seriousness of the patient condition, he decided he should get to the patient admitted to the intensive care unit for stabilization and further workup. He called the senior resident for the ICU and explained the situation. The resident chided him for not being too able to manage exacerbation of COPD, but agreed to come and see the patient. Just as the resident arrived, the patient monitor showed a ventricular tachycardia and the patient arrested. A call was called, and the team worked on it for 30 minutes to no able. The patient was pronounced dead at 5 a.m. Now, Dr. Rivera is going to explain you something about what happened here with this clinical case.
Good morning. My name is Jairo Rivera. I'm an internal medicine doctor. This is a new way to see how we can improve our approach to the patient who is out of our care. But first of all, we want to talk about autopsies. Autopsies are needed because we need an advancement of medical knowledge and the understanding of human disease. Autopsies have been made about 100 years. During this time, they had some role about how the disease can work and how we disease. This fits because we can make quality control. We can get some accuracy about our diagnosis, about the thoroughness of the process of attention and effectiveness of our attention work. So it is useful too because it led us to make the diagnosis and treatment of our patients when we know what were the mistakes or what the final cause of death of the patient. So next. An autopsy may be an anatomical process, and we can take out every organ from the body and see how it is hit by the pathologist or the physiological disturbance found in a patient who has died, for example, from sudden cardiac death, or a toxicological panel. In some patients, we don't have an idea about what was the cause of the problem, or molecular biology, looking for maybe the germ and the bacteria or the virus who was involved in the disease process of the patient, or genetical test when we have a history that maybe a father or maybe a brother have died of similar disease than our patient. This is a classical autopsy we make every time, and we try to study at the pathology course. But there are other ways to get some information or some course about how did the patient die. Next, please. This medicine, we always try to make this process, making the next steps. Next step. Next shift, please, Carlos. But what happens when we don't have a dead body? We don't have the body to study. We don't have a body at the moment we want to know why did a patient die, why did it go wrong. There's no way to know this because we're not at the pathology room. So we have some tools to make this some way easier. And we have clinical cases. The clinical cases, I explain how's the case, what happened to the case. There is not a way to know just this longitudinal chronological disease process, but I show you how was the case, how was the disease present during the death process. We can make to a quality case, and we can analyze what happened with the hospital or what happened in the healthcare team who attend the patient and said, well, this is good, it is not good, there is a problem when I feed or this not feed and the patient course of action. Then maybe the x-ray was wrong, or maybe the surgeon wasn't there, or the internal medicine had too many patients. But a quality case is not just our usual standard for analyzing clinical cases and death cases. There is another way to do this, and is a clinical pathological CPC, but not the CPC with the body, just the tissue. We extract from the patient, and maybe with this we can explore how was the process that maybe took the patient to death. But it's just, for example, bone marrow or hair biopsy, or maybe a muscle biopsy. And from this, we can construct or all the final cause of death. But there's another way to make this, and maybe it's the root cause analysis by cognitive autopsy, knowing what was the problem, what were the feelings, what were the cognitive errors our cognitive process took to the final destination of our patient. Next, please. The first problem here is that when we make a root cause analysis, per se is the word root cause analysis, because a root is just a single way to see the problem. And if you see, there can be a single root or small pieces like a puzzle to make all the frame complete. But this is a very flow prediction view, and these decisions can have so many caveats that maybe you can see what is beyond it, and maybe it is simple narrative and not all causes taken in account, like the 5 whys. The 5 whys is a way we can analyze why did a problem appear in a patient, but it is taken from the car industry. When a car is failing or there is a pipe not working in the car, I make 5 questions. This 5 question is about what happened in my car, why it doesn't start. Maybe I didn't start the switch. Why didn't start the switch? Because I don't have a key. Why do you have the key? Because I left the key at my house. Why did you left the key at the house? Because I left too soon and I forgot to get the key. So the final problem or the root cause of analysis was you forgot your key and you cannot start your car. This is the way I can make the root cause analysis, and the problem could be really, really, really finished and over. But there's another way to see this, because in medicine, there are so many ways to treat a patient, so many mistakes that can be committed, that it's important that the clinical or the analytical takes us further. Next, please. So an example of this is, for example, one patient medication error. Why it happened? Wristband not checked, wristband missing. Why wristband printer? Why? What? Wristband printer of the unit was broken. Why? The label was jammed. Why? Poor product design. So the main cause of the problem was the printer was not working, and it took us to a problem. But another way to see this, the right question was one patient medication error, wristband missing. Why? Wristband printer in the unit was broken. Why? Healthcare system purchased an unreliable printer. Why? Poor process for evaluating and purchasing non-clinical equipment. Why? Equipment being non-clinical is not seen as a safety critical. So there are so many ways you can see a problem by why, and why. But next, please. This has some disadvantage. This is when we're considering an autopsy or a patient who has died, there is not sufficient deal with individual decision making, the cognitive issues that underlie the clinical decision making. For example, there are 2 questions and it stops. Why wasn't a more complete history taken? And why was the physical episode insufficient? 3 more whys are missing. So our root cause analysis stops. In this case, we have so many variables that we must take in account that if we make a why clinical root cause analysis, there we are stop, and we can continue to explore what was the mistake or how was the clinical problem not resolved by our intern student. Next, please. So if we're studying at Sahara and we are looking at these are, always remember there can be what we call an espejismo. And this is for a complex problem, there is an answer that is clear, simple, and wrong. This is common because when you have a patient with dyspnea, you can think this is just heart failure or this is COPD, because it's simple. And simpleness is the way we think every time. We are going to buy a pizza. I want a pizza with cheese. I don't want a bread with maybe some pomodoro sauce. I want cheese, jam, and pomodoro sauce in it. So for every complex problem, there is an answer that is clear, simple, and run. We can think this way. And this is another way we can see it. We see at it is what you see is all there is. And this is about it's all the things that fit in that problem that make the things clear to make you think that the ascertain of your thinking is right. And when it's right, you're thinking, you try not to just go further. You get comfortable. I'm here. I just thinking about is dyspnea for COPD, and there's no problem. There is no any complex problem here. So the car goes on and the problem goes on, but I try not to respond the clinical question or clinical queries that are important to perform a new cognitive approach to this patient. Next, please. So the cognitive autopsy is a process that is going to let us to understand what was the problem when I start attending our patient. Maybe I did not take enough information from the patient. Maybe there was a problem with a bias or my affective behavior. And this can be a process we can do on our information. Because remember, we have thoughts and we have anatomy, we have how can I say it, maybe a building in our brains that is trying to construct every time some new issues to resolve. But if we see these, we have some critical steps that can make it easier or harder to get to the final destination is diagnosis and treatment of the patient. Next, please. Next, please. So medical error, when I see a medical error, there is no reason to feel we are going to do this by our own profit, because bingo no share is so important. There are a medical error that are effective error because we are feeling wrong that day, we didn't sleep, we have a problem with a wife, my child is sick, or maybe it didn't sleep well, or I'm really burning out because I'm making so many turns, so many shifts during the week. I'm tired. Or maybe there's a cognitive bias, and it's this cognitive bias make me think every time what I see is what I think is fitted to me to get the patient treatment. And there are other simple and complex problems that maybe we can try to explore, but we cannot forget this is a process that makes us think about what was the root cause analysis? What was the tree of the problem? Next, please. And remember something, we are wizards. We try to make always assumptions, taking account some findings, maybe this dyspnea, maybe this heart murmur, maybe this is wheezing, maybe we have edema, or we have a history of smoking or exposure to biomass. These make prediction rule to everything. We use it, the bias theorem, to get involved in the clinical reasoning process. But remember, our diagnostic failure rate across internal medicine is about 10 to 50%. Maybe you can tell, oh, well, we make a 90% no mistake or 85 no mistake process, but there's a 10 to 50% probability of error. This is not something that we can forget. So the puzzle is open, and we should take in account upon this. This is important for our to be self-aware of taking an account or taking so many decisions when we make a patient, we attend a patient. Next, please. So we have some theories that cognitive medicine try to understand how we think and how can we improve our clinical reasoning process. I don't know, but I want to study internal medicine. I want to study medicine at the med school. Anyone never told me how doctors think. Nobody told me a structured approach to how can it resolve a clinical problem. We call it the approach, or maybe some call it el enfoque. But I don't know what, never anyone has told me, look, you must take this into account, this is important, so this is the critical thing, we make always this is the critical sign, or this is the critical symptom, but maybe this is just an approach that is simple and doesn't make me think how really I think about the patient who is in front of me. So the dual process theory tries to understand there are processes that are inside my brain, that it's not only anatomical, it's also behavioral. And next, please. And it's a process that needs some issues to be resolved, to be really interactive and clinical problem solving. So there are two process that make our approach to decision making clear. There is a type 1 approach and a type 2 approach. The characteristic is basically which route can you use to resolve the problem. But the type 1 style is heuristic, intuitive, so the dyspnea is heart failure. The type 2 is systematic, analytical, he said, but wait a moment, he has dyspnea, but there are so many causes that produce dyspnea, so I think we should start looking for these cases, and my brain is starting to think slow, and there is some way we cannot resolve, but we take a long time to resolve a simple problem. Also, there's a cognitive awareness, and type 1 thinking there is a low awareness about the cognitive, is just dyspnea, is heart failure, period. But at type 2, there's another highway to see, excuse me, this is not. This is, again, a conscious control about our decision making in type 1. In type 2, there's a high conscious control. In type 1, we don't verbalize our thinking, we just make it. At type 2, we try to verbalize our thinking. And type 1 is automaticity, is dyspnea, just get a normalization. Type 2, there is low spec. Wait a moment, it's not going right. There is something we are not seeing. There is a mystery here we have not resolved. The cost the mental cost, or the cognitive cost of type 1 thinking is low, and type 2 is very high. The rate of thinking in type 1 is really fast, just do it. And in type 2 is slow, take it down. The reliability of type 1 is not so main, it's not so good, but in type 2 is really high. The errors are, type 1 is this normative distribution, so it's common, but in type 2 there are few problems, but the problems the errors we have are really large. When we see the power, the emotional balance, the detail of judgment process, and scientific rigor, and type 1 is really low, the predictive power, but the emotion we have about the problem we are resolving is very high. Maybe I'm happy that day, or I just sad. I just take the decision because this kind of, or this type of thinking is so emotional. At type 2 thinking, there is another, is the antagonist, is so high, predictive power, the emotional are down, the intelligent or judgment process is very high, and the scientific rigor is really high. Next, please. So if I want to make this the process per se, we can see this on this representation. So the patient presentation, maybe dyspnea or heart chest pain, just gets me, I get the history. There is a pattern perception in my mind, and it says, well, I recognize this chest pain or dyspnea. Okay, go to type 1 process. This process is hardwired, emotional overloading, and implicit learn. We'll see what is this at the next sheet, but it takes just only to diagnosis by this way, and maybe we commit mistakes. We can make some calibration of this process because I think maybe this is not good. My mood is not good today, but I try to calibrate. Maybe it's not just about the dyspnea. Maybe it's heart failure. The dyspnea is another cause, not CPD. Maybe it's asthma. Because I think today is my good day. I think I feel like this is my asthma day. So this is a way we can process. And this type 1 process is not wrong. This is the process we make every day when we see a patient at the ER or our clinical round, we resolve the problem. And this is useful because we can improve the treatment of the patient who is here with us. But if we have a non-recognized pattern, we have a type 2 process. This process is most knowledgeable, rational, and logically. This is the way we see some common, some ways of thinking. Maybe, wait a moment, please. Repeat me, what was the problem firstly? And well, it fits on my pattern recognition. So the chest pain, maybe 5 differential diagnoses, and I get the final diagnosis. Oh, don't worry, you can push it to the type 1 process and get an answer. But when we are trying to resolve the problem and we say, wait a moment, there's something that it doesn't fit in the puzzle. Maybe this is wrong, maybe this is not going good. There is a executive override, and this executive override tries to make a calibration of type 1 process and fit it to get it the real diagnosis. What happens here when the type 1 process goes on and there is not a way to make a type 2 process? This is an irrational override, and immediately the type 1 process fits the type 2 process. Then the next time we approach to a patient who has a similar symptom, we have a way to think in an unconscious way. We already make a type 2 process that save us from committing a mistake in our patient. So this is the way we think, and it's a way we try to understand how doctors make mistakes when they are trying to make the process, the thinking process. Next, please. So when we try to make a decision, we have some bias or bias decisions that make us think or fit our assumption of the patient. Maybe there's relatively derived from reality, occur systematically, occur involuntarily, are difficult or impossible to avoid, appear very distinct from the normal course of information processing. So the bias are the way we have to defend ourselves from making mistakes, but the bias themselves can make us make mistakes. This is something like, I don't understand that. What did you say? You said the bias are a way you protect, but the bias are also a way we commit mistakes. Yes, because the bias are a tool our cognitive load have to resolve problems and avoid to make the mistakes. But if you're always biased by the way you are thinking, there will always be a new problem you cannot solve because it was every time there. For example, I think I have saw 5 AMs COPD the last week. So the next dyspnea patient with dyspnea I see is another COPD. That is an availability bias because I have the bias that's always the IC is the COPD. How can we improve the way we attend our patients? We're making the bias in process, but this is not so easy, and we must train ourselves on our way to recognize our own bias. Next, please. For example, this is some bias availability. For example, to consider diarrhea as a manifestation of irritable bowel syndrome, given its high prevalence in young women without properly appraising the whole clinical picture. Representative bias to consider the Lyme and ART only as a manifestation of endocrinological dysfunction or growth disorders, rather than a possible consequence of long-standing malabsorption. Confirmatory to disprove failure to recover anemia with iron supplementation as a probability of malabsorption, anchoring to consider anemia as a consequence of metrorrhagia, as previously stated by gynecologists, prenatal culture to treat systematic diarrhea and anemia without performing celiac antibodies and intestinal biopsy. So these biases are common because there is a cognitive process that took us there. But how can I fight with my own bias? Well, there are so many ways, but let's the sheet we are going to try to discover how can this be done. Please, next, please. Type 1 process again is has its problems, but it's useful because it defends that. For example, the hardwired process is a reptilian brain, or reptilian brain is protecting us from making mistakes. So the bias anchoring and adjustment, repetitiveness, and availability isn't a bias that we have because it goes with us from our evolution. Well, evolution took us to think this way. So it's very hard to withstand this bias because we are born with this bias. Also, the emotional process, maybe I sad, the happiness, surprise, fear, anger, and disgust about the situation. And that situation makes me take a decision that is not right. Maybe some other linear process, for example, there is habituation without conscious deliberation. The general make examination, I take my stethoscope and all is hard, heart murmur is clear, low murmur clear, abdomen, no menses, no pathomegalogy, no splenomegaly. So everything's clear. I made this 100 times, and next time when I find something, I just making it mechanical way, and I'm not asking, why are you doing this? Why could you do this process in this way? Maybe there's something is missing. Maybe you should start thinking about what is that. But this is step 1 process thinking, and it's not wrong. It's just you must improve your way, the way you attend your patients. And this is another way and process that is important, is implicit acquired process. For example, the hiding curriculum, the things we hide because we just do this way all the time. Don't worry, it's fine. The ECG, read how we read it. There is no way, no need to see what is the QRS. No, you see the ST. Don't see it's white QRS. No, it's not white. It is always so this way. It's how we feel. Our community always has read the S-rate this way. So do this every time this way. Cultural behavior. Don't worry. Let's take a coffee. The patients can wait. There's no problem. We can go later. Don't worry. It's always the same patient who comes here with the chest pain. It's a comber. He's not good. He doesn't have a heart attack. He's just making an assumption. So get it clear. Give him some Dolox and send him home, or maybe paracetamol. Send him home, no problem. This is a type 1 process. And with the type 1 process, always leads from the type 2 process. But when your type 2 process is short or is not thinking about what is going on, why does this happen, there will be problems in our attention. Next, please. And did you see this? These are the common experience we have to open mind or try to understand why we make mistakes. The first will be the A, and intellect, knowledge, gender, ethnicity, experience, age, culture, religion. That is our behavior like a person. But there are other things we must see. For example, the personality, the critical thinking approach to the critical thinking problem solve, the rationality of our assumptions, the experiences, the reflection, the metacognition, the adaptiveness to the problem solving, the perseverance, the mindfulness, the lateral thinking, and the need for cognition. And again, we can have some situations that make it not so clear, like the stress, the fatigue, the sleep deprivation, the cognitive loss, overaffective state, and the sleep debt. Also, there is the system design we are trying to respond. For example, there's a disordered ER. We don't have enough communication. The technology is not enough. The team is not cohesive, and the scheduling is so many shifts. I'm tired, I cannot think clearly. Maybe when I want to see the disease, I cannot afford or cannot make the connections for symptoms, the onset, the progression, the right questions. I'm not doing it. And the F or the F, the process, maybe the patient, the family, the other patients or the friends that are around me trying to explain me what happened to my patient. Next, please. So we can see how this cognitive process make us harder to think and how can we resolve a problem. But this is the model called the previous model that tells us how people acquire competency and expertise. Next, please. This is how it works. It tells us, well, you have a clinical problem filter, you have your pattern processor, so it's not recognized or with recognized. If it is recognized, it will go to type 1 process and you try to respond it. Maybe you can process it and resolve the problem. There's no other way to make it. But when it comes to the type 1 process, it becomes a routine expertise, an adaptive exercise that tries to resolve all the time the problem. But always there is a teacher or a senior doctor in your mind that tells you, come on, stop. There's a mind work gap. You must, that this type 1 process, make it rational, put in critical thinking, processes, metacognitive processes, lateral thinking, flexibility, creativity, and innovation to your type 1 processes. So we can improve our approach to the patient. And when the pattern is not recognized, we start the type 2 process like a novice, then we start to make it an advanced beginner, a competence, a proficiency, and routine expertise when we are R3 resident. Maybe my colleague, Carlos Arteaga, was on R1, he used what is this, teacher? I don't know, what is this? But now he sees it that the board, teacher, this doesn't fit. It's so easy. I see it and it's this. But when I asking this question, hey, Carlitos, but don't you think there is maybe something you are missing? Oh my God. He says, I will activate my type 2 process to start thinking rationally, with critical thinking, with a metacognitive process, lateral thinking, with flexibility, creativity, and innovation. Next, please. So what happened in our case? There was a problem. What was the cognitive? What was it really cognitive process in our case? Because we are here to solve an autopsy. We invite you to solve an autopsy. So why are you talking about this? Well, let's please. When we are going to make a cognitive autopsy, we must know what is it and how it works. Next, please. At Wales, we have the guideline of Wales for cognitive autopsy. They have a guideline for all the emergency medical physicians to do it when they have a problem. And they say, look, this is not a process that is going to punish you. You must know you are going to make and to know what were your mistakes when you attend your patient. And this will make you better, doctor. So this is so good because the reflection made by the physician permits him to resolve the problem. So if you're going to make a cognitive autopsy, we should conduct as soon as possible the problem start, get all the information that was in that moment, reflect all my thinkings in a blank page, take it, all my feelings, what happened. Don't discuss the patient with other colleague to avoid maybe the feeling that we was wrong. This is a personal process. After that, you can compartir the process with the other colleagues. Try to work to the day from the beginning. How was your day? Do you sleep well? You don't have a nice day. You have many shifts that week. You fought with your wife. Your girlfriend left you or your boyfriend left you. Try to write all that things down. Next, please. And and make it rational. Consider the event and make your own questions about the problem. For example, do I feel comfortable with my judgment? Was the patient comfortable with my judgment? Was clear what I said to him? Was clear what I approached the patient? Reflect, does it make clinical sense what I made? Did I put enough effort think about the case? Did I hide biases when I think about the case? And manage it. Do I need more information or skills to manage this case better? Consider the ambient condition. Was I busy? Maybe I had another patient with an IM, or maybe there was a stroke. Maybe I was just thinking about my wife, or maybe there was so many noise at the service, or there was so many blood that I didn't feel comfortable at that space. How was that day? Maybe a conflict at home, one family member. Maybe that day that was not my day. That it was a bad day. And then after all this, consider your cognitive bias and try to make it accomplished to think this was right or was not wrong. Remember, the bias are not wrong. It's just a way we use to defend from our mistakes. But it's reptilian. It's hard adaptive, so we can make many mistakes by bias. Next, please. Our case, the autopsy I made was, well, the patient had COPD, he had dyspnea, he has a history. His chart says he has COPD and he gets the ER with wheezing. So he was wheezing, and in turn, I'm looking to resolve a problem. It's 3 a.m. I'm really tired. I had 5 shifts the last week. I'm really tired and I couldn't need to get a COPD at the ER. Please, this is not for my. So it's wheezing. Get a nebulizer. Well, I nebulized the patient. Why? Because he had the inflamed bronchi, because he has COPD, and the wheezing is for the COPD and the narrowing of the bronchi, where the bronchi is inflamed because there is a problem with the bronchi. And this is a COPD exacerbation. But I didn't think there's another way to think that maybe the bronchi is not inflamed. It's just about edema of the bronchi that narrows the space for air passing through it, and it wheezes. Oh, I didn't think about it. So I nebulized, because nebulizations are the way we use the bronchodilators to open the airway and improve our patient. Well, my patient improved. It's a COPD exacerbation. There's no other way to know it or to see it. And that murmur, it had the no murmur. All right, don't worry. It was known. It was all the time was there in this patient. So don't worry, man. It's there. And there's another way to see it. The ER physician said it. This is a COPD exacerbation, no problem. But he did not say this is likely to be a COPD exacerbation. If you see, the second answer or the second affirmation is more accurate. It tries to tell you, maybe you don't think about it. Maybe this is not just what we think there is. So in this problem, there are so many bias and so many cognitive ways to see it that maybe we have a positive probability error because we made an assumption it was a COPD. It was not a way to see it. It was just a COPD that was exacerbated. And this was a failure to, unpacking failure to say, maybe this is likely to be a COPD exacerbation. So there was an unpacking failure. Also, there was a confirmation bias because our ER physician told us it is a COPD. Our internal medicine resident told us it was a COPD exacerbation. There was also ascertainment. I said it is a COPD exacerbation, and all the framing, the cognitive framing said this is a COPD. Also, my internal medicine resident told me it was a COPD. The ER resident told me, physician told me it was a COPD exacerbation, and the ICU doctor told me this is COPD exacerbation. There was an authority gradient. They know more than I know, so I cannot disturb the top. Also, I was in Hanover Road. It was 3 a.m. I was really, really tired. And also, I gave the problem to the critical care physician to continue the attention of the patient. I was fatigued. I have sleep inertia. I just make the orders. I didn't think about any other variable on my patient. There was some dysphoria. Come on, it's 3 a.m. I'm tired. Don't call me for this. It's another COPD exacerbation. There's no need to go there and attend it. But also was a diagnosis momentum. So if the cognitive autopsy tells us that there are so many ways to see the problem that we didn't solve it right. Next, please. When we see all the thinking process, we see there are so ways, maybe the affective state, the knowledge, the experience. There was no the big cluster of thinking. There was clinical thinking, novel logicality, mindfulness, that kind of thinking. Just was about patients, seeing symptoms, system design, and resolve the problem. Just one process, one solution. Next, please. So there's the explanation. What we didn't have this problem, no result. Next, please. And Carlos, please finish the finding of the autopsy, the clinical autopsy made to the patient, and we see how this ends.
Okay, doctor. So the next day at 7 a.m., the intern went to the floor to begin the daily rounds. There was no discussion about this patient's death. He had very little sleep, but he had no time to rest and needed to get with the day work. So later in the afternoon, the intern was stopped by a senior physician who asked if he had heard about the autopsy result for the patient. The physician told him the case of the death was an aortic stenosis and noted that the surgery may have saved his life.
Next, please. Excuse me.
Don't worry, so the intern thought that the cardiac murmur he had heard when examining the patient was a systolic ejection murmur of aortic stenosis.
This is a clinical case. This is a cognitive autopsy made of an amazing. This is a real case, and it's called "Miss It" by Michael Green. This is a good way to understand this process. But we could finish here, and you say this was a cognitive autopsy of this patient. But how can we learn from this case? Next, please. How can we solve these problems? How can we solve it? How can we reflect these problems on our students and as experienced physicians? Next, please. Well, this is an example. This was a resident student I had with my clinical ground. This is her thinking about how to resolve a clinical problem. He had a problem with a patient, but he needed to understand how was it. So I made him just make your mental map, try to acknowledge what were the mistakes, what are you missing, are you thinking? I'm trying to make it, and she made this. I don't know maybe your script doesn't fit, but I can see you later. Adriana made a good job here. She understand. She had a way to think, and she made it clearer. And she said, "Wow, this is useful because I can explain what was my thinking when I was doing it." Next, please. The first way is promoting optimal clinical decision making. People assess probabilities incorrectly. They test hypotheses inefficiently. They violate the absolute utility theory. They do not properly calibrate degrees of belief. The choices are affected by relevant context. They ignore the alternative hypothesis when writing data, and they display numerous other information processing bias. When my residents with me, I tell them, and what if this is not what you think? What is the worst scenario? What is, if this doesn't fit on what you're thinking? What is real the problem? We should do this more common on our medical grounds. Make them assume that all they know is clear. Maybe this is an espejismo of the clinical thinking. Next, please. We must use some process, maybe metacognition. Metacognition is Hey man, how are you thinking? Are you really, really sure that your approach is clear? Or there is another way to see it? Maybe you should see yourself and look at your thinking process. Have more innovation, flexibility, and creativity. Hey man, there's a party out there. Go and dance like nobody does. Explore your violin technique. Make it clear you have the piano technique, or play so many video games, your mind get improved in how to resolve problems. There is a flexibility, innovation, and creativity, and make it then feel good with the self. Make some explicit promotion of thinking skills. Maybe you can make some more clinical problem solving, maybe more cognitive autopsies, or maybe you must have a curriculum with a clinical thinking solving, or a clinical problem solving, or maybe you may need a clinical reasoning curriculum on your residency. There is missing maybe. Also, make some lateral thinking about what you see is really what there is what there is. This is really, really clear. Make some lateral thinking. I call it not making the unorthodox way to see the problem. We are always orthodox. Maybe we be more flexible thinking. Next, please. Mitigate our cognitive bias. There are some bias, the biasing process. We can do it to improve our understanding of problems. Use the artificial intelligence. There are so many problems solvers, and there is a Kahoot program. I didn't bring it here today, but I would like to share it with you some other time. Make some this recognition. How does it work? Just tell a colleague or make your team clear you want to resolve a problem that is not clear. Working team, distribute your cognition, know the cognition, know what are the cognitive bias, and share it with others. Maybe you can solve the cognitive problem cognition. Next, please. And there are so many ways to make this. Maybe with the Professor theory, a cognitive affective bias, recognition, probabilistic reasoning, numeracy. We use it with the teacher Fabian Jaimes when we told about the statistical and how about we can use it. How is the collectivization to your insights? Try to understand the inner intentionality of medicine. Try to make the philosophy of medicine not just numerical. Make it more clear your cognitive process. Next, please. Knowledge of scientific reasoning. How do I reason? What are my reason? What is my reason about a problem? Make the rules of logical, scientific, clinical problem solving more clear to anyone who is listening to you. And also make the economic thinking. How do you think? How are you improving your thinking process? And avoid cause in diagnosis mistakes. Next, please. It's over, right? So I forgot. Look, it was the last one. I had a cognitive bias. I thought there was another shit on this presentation. So colleagues, talk, please. This is our space. I want to hear Carlos, Professor Fabian, maybe Juan Esteban or Carlos, or anyone else, to think, what did you think about this? This is useful. We should improve, we could improve our residency program if we make so many improving our clinical thinking. What do you think? Tell me, do we need some way to make this effort more clearer and maybe made it not the hiding curriculum by the curriculum itself in your residence program? What do you think about? Tell us. I want to hear you. Charles, Carlos, want to hear you too. And thanks in advance for Carlos because he made a big job. He made this clearly, real clear, and he made it. He told me, I want to do this. I want to thank him for this moment in his life. I know speaking English is not easy when you're not using it every day, but we must do it. We must talk. Thank you very much, and I want to hear you.
Thank you very much, Professor, and thank you very much, Carlos. We are aware that you have made a great effort, and we appreciate it Thank you very much. One comment I want to say is that we use the type 1 method all the time because we think that it has worked already for us in the past. So we love it because it has worked. But when things go wrong, when the patient is not going well, we have to, unfortunately, at that time, starting to use the heuristic and probabilistic and cognitive reasoning to solve the problem. One way I have done sometimes this is thinking in loud voice and think and talk with yourself. What can this patient, what is this diagnosis of this patient? Speak loud. Like swelling, tachycardia, dyspnea. Oh my God, he has pulmonary embolism. Go for it. So I think it's a good way to equilibrate the cognitive and affective bias that flags the type 1 method of reasoning. I don't know, any questions of the audience? We are aware of that. Thank you very much, Professor.
Anyone else have any other question or maybe an report or another thinking about this thinking? Professor Fabian, if you are there, I would like to hear you in your experience. How do you think this could be used at the residence internal medicine program at the Universidad de Antioquia? Or maybe
I talk now?
yes, please.
Hey, very nice activity. Congratulations. Very good, very interesting, very productive, very nice. I have a concern or I have a question about this dual process theory. I am not sure if there is a clear separation between type 1 and type 2 in terms of the daily activities for a clinician, because it seems to me at least that there is a kind of combination between the clear reasoning with the patient, and at the same time, in some cases, you need to do a more elaborate process of rationality. So I think that in some cases, in particular, maybe that we need a combination of these two types of reasoning, type 1 and type 2 at the same time and in the same patient. I don't know, what do you think about this situation? Thank you.
Thanks, teacher. It's right. When you are making a type 1 process, you're always thinking, this is just heuristic, and it goes there. But when you are having some proficiency making, maybe you have more time evaluating patients, you make it automatically. Your brain tries all the time to make the two processes to fit one another. The type 1 process always has the backup from the type 2 process. But when you are so overconfident, you forget to do it. And in that way, there's the problem. When you are overconfident and you don't use it to think just about the type 2 process, sometimes you are just going through the line and you're not taking some shortcuts to make the clinical problem solving. But in some way, there are some moments the clinical process thinking when the clinician starts to use more consciously the type 2. But the problem is when it uses all the time the type 2 process, it slows him down. And with slow him down, it makes him so inefficient in her make-up round. So it doesn't fit. But if you see Carlos, please take us again to the clinical process slide. If you see the process in itself, Carlos, are you there? Carlos is sleeping. Maybe he's on process 1. He says it's still in process 2. The cognitive process, please. the graph. Back, 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 again, back, back, there. Next. The type 2 process always tries to fit the type 1 process. There is the green line, the green dot line, and the circle line. See it. The type 1 process is always taking information from type 1 and type 2. They are interrelated. So this is the way they try to avoid mistakes. I think that is the explanation, teacher. I don't know, professor, is that clear? Someone else have any other question? I can hear it. And I have a question. How many cognitive autopsies sure what residents do during the information? They made some clinical autopsies, maybe 1 or 2, about their mistakes. How did they think of their rational thinking? What do you think about it? What do you think about the resident, maybe Juan Esteban or maybe Oscar? What do you think? How many cognitive autopsies should you do to the information?
Hello, good morning. Dr. Jairo,
morning.
Are you listening to me? Are you listening?
Yeah, loud and clear.
Okay. Jairo, thank you for your excellent presentation. First, how many? Probably none, for at least during the residency and during medicine career. At least for the moment. But I think we have to start like doing more of this kind of thinking and trying to understand why do we have mistakes with our patients, and this way of like dissecting a clinical case and knowing which are the different cognitive bias can help us with knowing why do we make mistakes and trying to avoid it. I have 2 questions. The first question is, do you know any program, like any medical program that is like teaching with clinical cases, for example, like you did today, with this type of cognitive biases and how to avoid them? That is my first question. And also, I want to add in that question that maybe I think the help of other disciplines, for example, psychology, that are probably more experts in this kind of cognitive biases. Do you think they could help in like how we learn to avoid this kind of mistakes? That's the first question. And the second question is, do you know also any program or any hospital, for example, that is using machine learning for avoiding this kind of cognitive biases and the type 1 reasoning? Once again, thank you for your excellent presentation, Dr. Jairo.
Okay, thanks in advance, Juan Esteban. There is for the first question, we have a medical school there, University of Manchester at Oxford, the University of Manchester has a curriculum based on clinical reasoning. In the medical school curriculum. So the undergraduate are teach how to learn critical thinking and clinical thinking. They made this process conscious all the time, because the curricula has it as a main, how can you say it, main approach to medical education. And the second question about the psychologist, yes, we need a psychologist to make a cognitive autopsy, because there is a need to understand how we think and how can we feel the way we make mistakes. When we make a mistake with a patient, we always have that mistake in our heart, and always is there taking us to, I made a mistake with this patient, and this always make me try to protect me from making more mistakes when I attend a patient. But we need a psychologist on our clinical ground, on a clinical formation, because the affective process that may us make decisions is too important to be avoided. And I think the university has the educational and psychology resource. There should be a curriculum with clinical reasoning curriculum and the accompany of the psychologists in it. I invite you to read this. I send you some clinical studies about this. That is a opinion paper from Principles to Practice Embedding Clinical Reasoning as a longitudinal curriculum term in the medical school program. It's published in Diagnosis. It's a journal of diagnosis and clinical reasoning, and they explain how they took it into the clinic, the residence program. I'll share it with you. I hope the question maybe is solved. I don't know if there are other questions, and if it's not, I think we can finish. We have 1 hour and 6 minutes now, and the time is important to all of us.
Yes,
I don't know
thank you very much, Dr. Jairo. And I want to say you something, and happy birthday to you.
Thank you very much, Charles. This is a new day and new life. This is changing. I thanks in advance you because you heard me today on my birthday. It was just 56%, but I think they were with me. Thank you very much. And I hope next time we can enjoy it again, and maybe we can make this clinical reasoning curriculum in your clinical formation. I hope the internal medicine residency will be the best. I hope. And thank you so much.